I'd like to invite the panelists to the stage. We'll start with my friend and colleague, Dr. Rashid Badi, who is the director of the Center for Emergency Management in Ministry of Health in Oman. I'd also like to invite Mr. Dejan Panic, who's a program coordinator in emergency NGO in Afghanistan. And I'd like to invite Dr. Christopher Abeid, the Chief Executive Officer at the Nairobi Hospital in Kenya. And before we start our discussions, we will have interesting talk by Dr. Rashid Badi. The talk is entitled Academia in Practice. So without further ado, I'd like to invite Dr. Rashid to the stage.
Assalamu alaikum wa rahmatullah. Actually, I was expecting a small group to be presented to, but it turns to be a very big group. So I'll try my best to bring whatever we are having here in Oman. And what I want to say that we are not going to bring a new things for your knowledge, but I wanted to share our experience here in Oman, what we did, and how we do it. And what do we think that is the best for us, for the country? We could share it with others as a good experience for us. The panel's title, I think, is the preparedness of hospitals during crisis. But I wanted to change my title as an academia in practice, which I think it's very important to state that theory should come before thinking of going to practice, and it should be augmented with the practice. So it's not one line as an academia and then going to practice, but it's academia practice and then coming back to correct it with academia and then going back to practice. And this is like a cycle going through the whole process. So we started our system with a good practice. We saw what have been done in the past from our experience, and then we turn it with a good theory, with a good academic part. And again, we started with a practice with what we learned. So I'm going to talk about our hospital emergency management plan, and I mean it by hospital management plan, and it's not a disaster plan or an emergency plan. All what we focused in our experience. So all what we meant it by is to have a management plan rather than it's an operational plan or an emergency plan or whatever we call it. We want people always to focus on the management, because the management will break the whole what we did if it is not a good management. Then I will talk about the content of our emergency management plan, the aims, and important algorithms. So I'll take a part of this plan. It can be a help of other hospitals as well to initiate this part, because I have been looking for emergency plan of hospitals, and we try to introduce new concepts in our plan. Then definitely we'll turn this from practice, from academic part to a practice, which is a good experience for us. It was a historical experience. Mekona Cyclone 2018 May. This is what we built our management plan to. If you look to the chart there, time versus health quality. Once we built our health plan or hospital emergency management plan, we did not focus on what we heard as a patient-centered or providing care for the best care for more casualties. We focused on one thing, that how can we maintain our health services for all people during emergencies, whether for the affected population or non-affected population. Because in the past, what we used that once an emergency coming to our hospital, then the whole hospital focus on that emergency, then they forget the rest of the population. The continuity of the health service was our focus in our emergency plan. So we turned the focus from management of that incident to how would you maintain the continuity of the health service during the emergency. Definitely the first few hours, as you see, that the number of casualties will be high and the health service quality will be low, because you are providing the best for the maximum number, and that is with the less resources. Then how would you turn it for the maximum? If you don't, that few hours will collapse your system, as a quality management for that number of patients and the health service, or to initiate it. And that is the area, the initial part where we focused. That is the part where our emergency management plan will continue. So we introduced the concept of hospital emergency response team. Before, it was a call from outside or inside, where an emergency doctor will receive it and then will activate the whole plan. Yes, that is good. But that also will consume a lot of resources in the hospital. Then the next day, it's like a cycle. The next day will not be able to operate because all the hospital staffs, all the resources was consumed. So the next day will not be able to operate the same day before or with the same quality. So we introduced that intermediate. Instead of the one guy to judge if this is an emergency or a disaster or whatever you can call it, then that team, which is 24/7, 365, are already there in the hospital. So that team will come and judge whether to escalate the issue to a higher level or to maintain it and manage it by themselves in the hospital with no extra resources. We introduced as well the hospital incident command system to the hospital, which is also already there. We adjusted to our environment. And then the most important thing, we introduced the last, if you can see, the evacuation plan. And what we meant by the evacuation plan is not a normal evacuation plan, but we introduced the concept of the functional zones of the hospital. So instead of declaring the whole emergency in the health facility, we asked the engineering part to be a part of the clinical part as well, to divide the health facility into a functional zone where it can contain the electricity, the ventilation, the medical gas, as well the whole system can be separated from other parts of the hospital. So that's called a functional zone for our health facilities. And the health facility is divided into zones. We decided that if this zone is affected, then we can shut it down. If the emergency is not high up, then we move the patient to a specific zone. That is already well-determined zone from one zone to another. The operation will move smoothly. Definitely what we are using is what people tend to do and not what we ask people to do. Because if we just ask them that evacuate to zone B, people are not used. The nurses, the doctors are not used, who are the first responders, the first line, are not used to go for zone B. Then we had to introduce it from the beginning. It's not just only in the plan, not in our minds, but it has to be there in the plan where everybody knows about it. So the aim was to reduce the risk in main sectors, national, regional, and local levels, developing system of information, building a culture of safety and coping with risk at all levels, enhancing the preparedness and response of all types of disaster, reserve resources, coordinate the unit-level emergency response, and implement specific emergencies management team directives. So it was different levels for all our health facilities. That one hospital will say level 1, 2, 3, 4, 5, and the other will say level 1, 2, and the rest will say 1 or 3. So we wanted to unify the levels of activation in order for us as a central level as well will be able to coordinate and to interfere at the right time. So if they say we divide it as a minor emergency, where the HERT team, the hospital emergency response team, is intervening and managing, we divide it to a level 1 where they can cope with their own resources, and level 2 where the international efforts, the central part, could help and could manage the resources themselves. Coming from hospital management plan as a theory and a practice, we practice it. We started this plan in 2017. We introduced it in 2018 because we had to make, as a central level, as a body who is coordinating this type of plans, to make a core content with which all hospitals should follow. Then they can add whatever they want. But the core content is very essential for us. We had a cyclone, Mikono cyclone, in 2018, and a small brief about this. It was to the south of Oman, which is 1,000 kilometers away from the nearest, like the strategic hospital there, 1,000 kilometers away from the nearest secondary hospital to it. And the most important thing that this type of cyclone, they said it will fall around 600 millimeter of water, of rain, within the 24 hours, which is very huge amount of rain. And if you can see that Salalah or Dhofar is surrounded by the mountain up. The point from the shore to the mountain is around 15 kilometers wide. At the end of the residential houses is around something like 10 kilometers. So imagine all that amount of water will come at one place and it will go down. So usually the cyclones will come as 100 millimeter of water in 24 hours, something like 90, 150, but 600 millimeter in 24 hours, that is too much of water coming to this specific area. So like if we are having a swimming pool, if it was hitting directly to Salalah. So from the early warning center, we received the information as a central part, as an emergency operation center, which is our center here at the central level, where we coordinate all the efforts and we receive all the information from the early warning centers as a national part. And we send it to Dhofar that you will be having a cyclone. They know that they are having a cyclone, but they cannot imagine how much it will be affecting that services. And yes, there are other sectors in the country who is taking about of other things, but taking care of health, that is very essential for us. It's a strategic place, nothing near to it. So we send the alert to Dhofar, and we said, guys, be alerted, this amount of rain, and you cannot cope with it. And we stated clearly that you cannot cope with it. What is your decision? Because that is their plan. Next. So they replied to us, we need your help. As a central body, we need your help. That means it's a level 2 activation for us. We understand it. When they said level 2 activation, then we understand that we should interfere. Next. So at the same time, we are preparing our resources. We activated our mutual agreements between the governorates because they have their own plans and they should help the central body. So we activated the whole nearby governorate to aid us with the resources. No governorate can cope with such an event at the same time with their own resources. Next. With the same time, we prepared a mobile medical team in the aircraft. We used the Air Force crafts to support us, which was a new thing for us to introduce the aircrafts, which is a strange environment for a civilian part to be inside the aircraft. Next. We sent the team. The plan was, inside the aircraft is a different team, which is composed of over 80 doctors and nurses. In Dhofar, in the affected area, will be a different team, and the receiving team will be a different team. Next. So next, please. All the ambulances were gathered in the airbase. Each ambulance was, we knew about what kind of patients will come from Dhofar to the airport with the name, with the type of the disease. So he will be in ambulance number 1. So that would be arranged. So you are, as a doctor, in ambulance number 1 will receive this patient at this time, and they have to take it back to their areas. It's not in Muscat, because Muscat cannot accommodate all this number. Next, please. 1 minute. So the mobile team in the aircraft moved back the patients to the north. The problem we faced, it's a strange environment. We had intensive care babies as well, the SCABU. The incubator could not fit into the aircraft, our incubators, because we did not test it as well. So we had to take them in the normal beds. And it was summer, nearly the temperature 40 degrees. And we asked the pilot to raise the temperature. And so it was a mobile flying oven for 2.5 hours. None even of the doctors could cope with this unless they are well trained to accommodate with such an exercises. Next, please. Next. So we transferred around 333 patients, including the dialysis units, and 34 of intensive care patients. We did an emergency dialysis units, which is a burden in our system as well in the north, around 146, and we sheltered 293 cases from the south to the north. So by our preparation of our emergency management plan, we could absorb the impact of that cyclone in a very short period. Unless we had that preparedness, that type of preparedness, which I can see it, we could lose lives. And that is very clear for us, that we could lose life without practicing, without having something which is ready to practice. Thank you very much.
Thanks, Dr. Rashid. Our next speaker is a humanitarian hero who actually grew up in an area of conflict in the Balkan War. But he decided, since he grew up in that environment, he decided to dedicate his life to helping victims of war in Afghanistan access healthcare for free. So he is a true hero, and it gives me a great honor to introduce Dejan to the stage to talk to us about what it takes for hospitals to be in capacity to respond and resist when there is a crisis. Dejan.
Good morning, everybody, respected excellencies, dear guests, ladies and gentlemen. My name is Dejan. I come from Serbia, and the past 10 years I've been living in Afghanistan, working for an international NGO called Emergency, which has deep Italian roots. So many would say that it's an Italian NGO, yes, and we are all supporters of Inter Milan. And Afghanistan is a country in active war, as is recognized. Daily, the needs are unimaginable to treat the victims that are coming, not just our way. I'm not here to promote our own organization, but to share the experience of what we do and how we do and why we do it. Emergency has been born in 1994 in the Iraqi Kurdistan, when there was a need. Experiences from Rwanda led us to Afghanistan in 1999, where we opened our first hospital through the civil war was still ongoing. Offering what? High quality, free of charge surgical service. To who? To everybody. Who came our way, who laid down the weapon, was ready to enter our hospital and respect the rules and the treatment care that we were offering to those who were less fortunate than us to be exposed to active war. Emergency is present in 11 provinces in Afghanistan, a country of 35 million people. We have 3 main hospitals, and on one of them we have also 3 different departments. So let's not speak just about war. There is great needs in Afghanistan: maternal health, newborn health, pediatrics, but emergency is quite well recognized for the surgical capacity that has built over the years. And I'm not speaking about us, the big internationals. I'm speaking about the true heroes that don't have the luxury to walk away from Afghanistan just like we do, to sit on a plane and fly away. I'm speaking about the local doctors, nurses, and non-medical staff that motivate us every morning to get through the doors of our compounds and shoulder by shoulder to work together for what? To save lives, to improve health, and to deliver the message that health is a universal human right, and it comes in a form of free of charge, that we don't take even a penny of what we are doing worldwide. In Sudan, where we do cardiac surgery, or in Sierra Leone, where we fight Ebola, or we treat traumatized patients. The presentation is focusing mainly on our work and where we are present, but I think that the message and the picture, what I try to paint here, is much bigger than that. Without the help of the World Health Organization, would not be possible. Definitely not possible in the past 10 years, where now we have the national capacity of doctors and nurses to respond to the great needs that are growing. From 2015, I would say around 30% the casualties of war increased in our facilities. About 3,600 admitted war-related patients in our Kabul hospital. 60% of them came throughout to the network of our first aid posts that have been placed all around the provinces and districts. And they are run by who? They are run by the national emergency technicians, health assistants, nurses, and doctors who daily risk their lives to deliver wounded people, or pregnant women from some districts in our maternity hospital in Panjshir Valley. What I would like here to point out, that war in Afghanistan is very far from finished. At least this is not what we think, this is what we can prove. So our personal perception here doesn't matter a lot, but with great help of institutional donors and the recognized need, our hospitals grew. They have been refurbished, they have been standardized, not just medically, but also non-medically. And here we are speaking about a big logistics operation, because a person who was, again, using the same phrase, less fortunate than us to be born in another country, when it comes down that he gets on the operating table, has the same right to be treated with the same dignity and respect than the people have in the Western world. We are trying also to be cost effective. Limited resources taught us throughout the years to manage carefully our funding. And many times I'm receiving the very strange look in the eyes of my colleagues from other organizations. How you are able to do it? If we would do the same, it would cost like 4 or 5 times. Well, I think that being self-grown and using experiences from other organizations that many of our founding members worked before, led us to a final conclusion that we need continuity and sustainability for a long-term project. We started as an emergency response in Afghanistan in 1999, but now, 20 years, we are part of the development. The third generation of trauma surgeons came out from the emergency hospital in Kabul and Helmand province, Lashkaga. Now the second and the third one are coming out as well. First generation of pediatricians from our hospitals came out, gynecologists. So this is the real pride and capacity that emergency is capable of. As my time is running short, I don't want to take too much, because I could speak for sure for another hour, but the final conclusion and my message is that if there would be more people in Afghanistan like they are working for emergency, I'm quite sure that there would be less war. Thank you very much.
Thank you very much. So we'll have panel discussion with Dr. Abeid as well with us. He's not going to present, but he's going to be part of this panel discussion. I would like to also remind you to put your questions on either the app or the website. And soon we will be displaying the questions, and we'll ask the panelists to answer these questions. We'll start with Dr. Abeid. You are based in Nairobi, Kenya. What aspects of healthcare challenges are you facing, especially compared to other areas? I know there is not a major conflict in Kenya, thank God. But what are the major aspects or difficulties that you find in your environment?
Thank you, Anil. I think I'll give you some historical perspectives first. In the last 3 decades, 1998, we had a major bomb blast of the U.S. Embassy. Yes. It killed at least more than 300 people.
Al-Qaeda.
4,000 were maimed.
4,000 were?
Maimed, injured.
Yeah.
2008, we had post-election violence. all over the country. We also had lots of injuries then. 2013, we had the Westgate. It's a very high-end restaurant in Nairobi that was attacked. We had more than 100 killed. 2018, which is just last year, we had another attack called the Dusit attack, which also had lots and lots of injuries and also lots of killings. Being a resource-poor country, there are many challenges that we face. The only response has been effective because of the primary institutions, private primary institutions. The public institutions are not very well resourced. So in the first instance, 98, for example, Kenyatta National Hospital, everybody ran there because there was no option. Outcomes were poor, we were not prepared. These other two have been well managed because the private institutions have taken the opportunity to resource themselves and prepare themselves. On top of this, I think what the government has done also, it has come up with the disaster response manuals, risk management manuals, and this has been cascaded down to the institutions. So right now, it is mandatory for all private institutions to have a disaster response plan, mass casualty incident plan, and also risk registers, and make sure that we do drills every year, at least 3 times a year drills. But this said and done, the main challenges we face are usually economical, infrastructural, and human resource.
Thank you. And did you notice any improvement, 2018 disaster compared to the American embassy bombing? I know the magnitude of the disaster is different, but did you notice any difference in the outcome?
Yes, I think it's glaring. The response times, the transfer of patients from the areas of injuries to the hospitals, that has been expedited. The government has now committed to have these policies in place to make sure that everybody who goes to any institutions in the country, whether private or public, they get emergency care. And I think people have also been enlightened. So people know what to do to protect themselves. People know where to go when they get this type of disasters. I can give you an example. For example, I know Rashid, he talked about Ebola in Sierra Leone.
Yes.
We are actually aware of those threats and we are preparing for them. You get screenings when you come to the country to make sure that you don't have a fever, for example. And we have isolation areas already allocated in case we get this type of emergencies.
Thank you very much. And I think this is for all the panelists. Feel free to contribute to this question. Healthcare as a road or a tool for peace. What is your take on this concept? Maybe we can start with Dejan and then pass around.
Absolutely, yes. It's one of the pillars in our strong beliefs that hospitals where patients are treated equally with the same compassion, with the same level of care, are a good place for a start of reconciliation. Focusing on Afghanistan again, in Afghanistan everybody lost something. A family member, an eye, a limb. Somebody lost even hope. So many times we are the last stop that patients can, people, as we said yesterday, let's not say patients, but people can regain their dignity again. Try to reduce the disability to be integrated again back in brackets, normal environment, normal war. But definitely health facilities that are equally accessible to everybody. As healthcare professionals, we strongly believe that the internal affairs of a country should be resolved by the people who are involved in them. And us, as doctors, as nurses, we should stay impartial. I'm also much more fan of impartiality than neutrality. Neutrality, of course, that goes by default. But impartiality, to have everybody access the same level of care, puts also a good protective sign on a health facility and reduces the possibility of being destroyed in an active wave of destructive war actions. So, absolutely.
Yeah, I think your question is how the health bring to the peace or lead to the peace. I think health will contribute to the peace, because that what we aim to achieve is not only caring the individual health, but producing a healthy society. So healthy society is a must for bringing the peace or solidarity or cohesion of the society. I think that's what we will going to contribute to this. And so I think our health sector people, I think we have done lots of things like Afghanistan, like Kenya and others. We produce a healthy society, which is the base for bringing the peace. I think that's a very important role we play.
Dr. Rashid, I think there's a question on from the audience. Two questions. Wow. Dr. Rashid is popular. Are there any additional local capacities in Salalah, like the Armed Forces Hospital, for instance?
Definitely, that details are not mentioned here, how this operation went through. It was not an easy operation to carry it out, but there were as I said from the beginning, our aim was to continue the health services for our citizens there in Salalah. So it does not mean that we have shifted the patients in the hospital to the northern part. Does not mean that we stop continuing the service in Salalah. So we used the Armed Force Hospital, which was a big aid for us, and the Heart Center as well, to continue the health services for the citizens. And we distributed as well. We took the whole, for example, the whole renal dialysis patients there, but we kept centers for dialysis as a satellite dialysis centers for the patients who are already there. So the Armed Force Hospital actually was a big aid. He was receiving the big chunk of the continuing of the service in Salalah. Yes.
Okay. And the other. So talk about preparedness, including training before crisis. Did the staff in Salalah receive training in advance too? The local staff in Salalah, I think the question means.
We started our, as I said, from the beginning that we started the plan as a hospital emergency management plan. So our focus was for the management. And yes, the leaders in the Salalah governorate, they received the trainers because they are our first line. And their second lines as a hospital directors and the emergency crisis section as well there, they received the trainers with others as well. So yes, they received, and we trained some emergency managers as well to how to deal. We could not succeed by doing it from here, from the north. It has to be done by the local citizen there.
Before we take this question for Dejan, I have a question again for the panel. Working in areas of conflict, one of the main concerns of the healthcare providers is the safety of the healthcare providers themselves. How would you ensure that, and is it a big problem, or are you protected? Maybe we can start with Dr. Abeid.
Thank you. I think I'll give you probably my experience. 10, 15 years ago, I was a healthcare provider with Medicine Sans Frontiers. And I went to a refugee camp, and that was the first question that popped in my head. But the most important thing is the NGO team giving you information so that you're aware, so that you're able to avoid risks. That's one. Number two, they also do some insurances to make sure that everybody's covered. Number three, of course, is the usual work environment, how to take care of yourself, make sure you're safe, make sure you're able to be evacuated in terms of when there's an emergency. I think it's all about awareness. As a healthcare provider, I need to know where I'm going, what type of threats I'm facing, and how prepared I am.
Yeah, I think health is impartial health, as you said, to provide the service to protect the life regardless of which side they belong to. I think it's important the international community, like us in this community, in this forum, to raise the voice that the health staff should be protected. They should never be attacked, and they should never accept whatever the reason is. We have bombed in the hospital in Afghanistan, we have killed the health staff in Syria, but we should never accept this, whatever the reason is, and because we are helping the life.
Dejan, maybe you can also answer this question, and the question is, have you considered providing hospital management and operations capacity building to other public hospitals?
Yes. Going back to the ongoing topic, for us generally it's very important to work with local communities, with local shuras, and that's why we are offering the first aid posts in the districts, whoever is controlling them. Are they armed oppositions? Are they in governmental controlled areas? They are the same people at the end.
And they respect this.
And they respect this. So this is, it's not easy. We've been in the country since 20 years. Some of the posts have been opened, let's say in 2011, 2012. I attended some meetings in 2014 in one of the safest areas of Afghanistan when there is no active war. And I asked them, but why you are calling us now to open a clinic? That says, we send our children to schools. Now they came back and they told us, we can trust you. So it took a period of evaluation. So the visibility and the concrete evidence is what you do on the ground with the people. So I'm personally not able to go to some of the districts, but the people who live there, they work for their communities. I just want to make it up, I will be fast. We are speaking about people who sometimes are barely able to write and read, yes. But they put on the white gown, and after a 2 months training, they become emergency medical technicians. They are transferring wounded people to the most dangerous areas, not of Afghanistan, of the world, to hospitals. Let's not focus just on emergency hospital, but hospitals that exist countrywide, thanks to the Ministry of Public Health as well. So
you're maximizing the help,
absolutely,
whatever you have.
Absolutely, yes.
On the field.
Absolutely, yes.
So can we go back to the question for Dejan?
I will just say that an organization is not a solution for a country of 35 million.
Of course, yes. You try your best.
Yeah.
Have you considered
absolutely, yes.
providing
There have been many talks on this topic, and I'm very positive that it will happen in the future. And we have been asked this many times to provide some insights, some training, how to manage a hospital, and we are very, very open for cooperation and any suggestion from the Ministry of Public Health as well. Absolutely, yes.
Let's have some more questions. Well, yeah, there you go. Do the politics division in Palestine have an impact on the UNRWA mission?
It's a very good question. A bit risky, but a nice question. The answer is, to be honest, yes. Because it's not only the internal Palestine politics, but more largely the politics of Palestine with Israel, also the Palestine in the Middle East, and the Palestine in the world. I think what I want to show today is that the real cause of the main cause of the ill health of Palestinian refugees is politics. The political determinants of health define the health of Palestinian refugees. In that context, the answer is always yes. And that is very important that we healthcare providers understand the politics, but raise our voices to make sure that the people do not unnecessarily affect from the ill health from the political reasons behind.
While we get the next question, oh, there you go. Thoughts of the panel on the preparedness for the emergency situations involving hospitals, whether earthquakes or man-made terror attacks. We'll start with Dr. Rashid. What do you think of the hospital preparedness in Oman, for example,
Right.
What is your assessment of the hospital preparedness in Oman?
We are trying our best to cope whatever risks.
Don't be
we are
political.
having. No, I'm not political. Actually, we are trying to cope with it. It's not an easy thing. It's not a day-to-day job. It's something which is unusual, and it might not happen as well. So people are more looking after certain things, more important, but emergency could happen. And at that time, when it happens, it could do a lot of damage. So we have been listening to do as an all-hazard plans, but what the trend we have taken it to do and to train human resources as an all-hazard approach. So we decided not to invest a lot in the all-hazard plan as a resources, but to invest more on the human resources to approach any incident as an all-hazard. So we just switch the things because we don't have a lot of resources for an emergencies. This is all what I can say. But I reassure you that, inshallah, if anything happened here, we are still prepared for it.
I can actually vouch for this because I dealt with Dr. Rashid in few emergencies, and I think it was the system was quite mature and very professional. I mean, any system can be developed and improved for sure, but I actually can vouch for, and I salute you for your efforts. Dr. Abeid, I think you can answer the next question. Role of pharmacists in disasters.
I think that's very clear. I think disaster management should have what we call the multidisciplinary approach, and pharmacists play a very big role in that. So I would say yes, they have a very significant role to play as part of the MDTs.
Right. Access to drugs in Palestine?
Yes. Or role of pharmacists?
Different from that.
Access
to medications for the refugees, is that,
okay.
Is that a big problem, or is it?
It is always a problem. This is one of the cost-driving factors. Anyway, that when the financial crisis hit the last year, when the United States government stopped financing us. But I just want to be honest that the United States has been the largest supporter for UNRWA for decades, so that I have a great respect and appreciation of this. But as a matter of fact, when the finance was cut, that what we did is we bought a minimum amount of medicines only, and that affects the continuity of care to some extent. And we are coming back by this one, but I think that's also that's important part. The second one is that how quickly we avail medicines in case of a disaster and the ones. I think WHO is having a humanitarian hub in Dubai. I think that's a great way to affect. And now we are buying medicine from India and the Indian subcontinent because this is all the cheap and the good medicine comes in. The quality control of these medicines is always a headache, and I think that's the international community have to work together.
Thank you. Dejan, you lived through 2 different conflicts. What are the similarities?
Well, if I go back in my head when I was growing up back in the 90s and comparing the Balkans conflict and the Afghan protracted one now, I think that in the Afghan one there is much less hatred and there is much more room for, as we mentioned, reconciliation. And as much as it's longer and people are getting exhausted, it's still ongoing. I don't think that is my place to say it why. I can say the what is ongoing as a representative of a humanitarian medical organization. But definitely that the people in both conflicts are looking for that little spark of hope that is offered. Is it through different state actors? Are they NGOs? But bottom line is that war, I mean, whatever.
Nobody wins.
I mean, you know, there is this saying that in this protracted crisis that only the dead see the end of war. I'm very sorry to say that, but in Afghanistan it seems that it's a never-ending story. And also our staff that are going from our mission say it's a kind of deja vu. What changed from 2010? It became just the trend is showing that it's getting worse. More people are getting injured, more resources are needed, more doctors, bigger hospitals. But where is the bottom line? Where is the end? So we try to invest in education, in a culture of peace, definitely.
Well, thank you very much. I think it's a very interesting topic, and everybody is enjoying and is interested in this. But I think we'll have to stop here. And if you excuse me, we'll take a selfie because it's very rare to have such a great panel at the same stage. Thank you very much, and a round of applause, please.